So thanks to everybody who's joining today. The response has been really overwhelming. I think we have more registrations than we've ever had for any of our other online activities. My name is Rebchook, and I'm on the faculty of the University of California, San Francisco's Division of Prevention Science, where I direct the CDC-funded Prevention Research Center, or PRC, and this is a PRC activity this morning. I'm a professor at the UCSF Center for AIDS Prevention Studies, or CAPS, and I also have the privilege of being part of the Center of Excellence for Transgender Health and the Health Equity Action Network. And I wanted to start out today by giving a special shout out to Dr. Beth Bordeaux, who's the Deputy Director of the PRC. And Beth really helped realize the vision of this training today. And our great team of John Hamiga and Ben Zovad, who are handling all of the logistics. So please feel free to send them a message if you're having any problems. I also wanted to acknowledge the Pacific AIDS Education and Training Center, who's really an awesome partner and helped us plan this event. And they're a longtime collaborator of us at CAPS and the Prevention Research Center. We couldn't do this without all of the people who were involved today. And just a little bit of background about where the idea for today's training came from, and that I think it's kind of timely because it started for me at last year's NMAC, the NMAC Biomedical HIV Prevention Summit in Chicago. And that I thought was just such a wonderful meeting. It was the first time I had seen a lot of people since the COVID epidemic began. And I think today's meeting is really timely because the 2023 NMAC Summit is being held in Las Vegas in 2.5 weeks. And I hope to see a lot of you in person there. UCSF is having a table in the exhibit space, and I just wanted to offer it up that that we could use that table as a hub for people who are here today. If you want to come by and say hello, talk about next steps, or to apply everything that we've learned here today, so that we could really continue this conversation and the opportunity to network with each other at the biomedical meeting in Las Vegas. So I'm really excited about that. And I'm super excited about today's training. We have an amazing panel, and I think their expertise and knowledge just has blown me away as we've been planning this. I learned something new in every meeting that we've had. And our panelists today are Tim Horn, who is the Director of Medication Access and Financing at NASTAD. Jim Pickett, who is a longtime HIV prevention research advocate and a senior advisor to AVAC. Kenyon Farrow is a writer, editor, and strategist, and he's currently the Vice President of Policy with Point Source Youth. And last but far from least is Jeremiah Johnson, who is the Acting Director at PrEP for All. And our current presentations are focusing on the current PrEP financing mechanisms and programs that exist in the US, the work of PrEP for All, a really detailed discussion and overview about issues affecting PrEP health equity, and then a discussion about the national PrEP plan and how we could realize the potential for that. After the presentations, we'll have an opportunity to ask questions to the panelists, and we'll have a discussion about what's necessary to help promote PrEP-related health equity in your local communities and on a national scale. And so then Beth, have I forgotten anything? If not, I'm going to turn it over to Ben Zovad for a minute, who's going to tell us a little bit about the technology that we'll be using today to help have more interactive exercises with the participants. So Ben, maybe you could talk a little bit about how to access and use the Poll Everywhere.
All right. Thank you, everyone. I think we'll move to the next slide. It should update on your browser. All right. So this is the region that you live in. And again, if you are using the text, remember to text PRC PrEP to 22333, and then you can just text in your single letter response. Thank you, everyone. And this is how Poll EV works. If you're continuing to have any problems, feel free to direct message me in the chat, and I will do my best to get back to you as soon as I can. Back over to you, Greg.
Thanks, everybody. So these are the objectives for today's training, and I don't think I need to read those to you, so why don't we just move on to the next slide. But we would like people to answer one final question in the poll everywhere. Again, please go ahead and write down one thing you would like to learn in today's training. And we may or may not cover all of the issues, but that if there are things that we don't cover today, we can use that to plan future activities. So please go ahead and fill that out.
And just a reminder for folks that may have just logged in, if you've gone to the Poll EV website and it asks you to log in, you should be able to just skip the login and it'll take you directly in.
Great. Well, as people are writing in, maybe we can go ahead and move to our first speaker.
And if you're on the Poll EV website or on your phone, you should still have that page open, and please keep dropping in your responses.
So Tim, can we, oh, I see.
All right.
Great. Terrific. Thank you, Greg. Thank you, Ben. I'm actually going to turn my camera off to minimize the risk of freezing. You should all still be able to see my slides. So with that, good morning, good afternoon, everyone. So first, I'd like to thank the Center for AIDS Prevention Studies for the opportunity to be with you all today and to share the panel with such a remarkable group of community leaders, all of whom I've had the pleasure of working and being friends with for many years. With that, can we start the first poll? Okay, so now that we know a little bit about everyone's sort of profession or discipline coming into today's program, we'd like for you all to take a few seconds to think on the most important facilitator of PrEP access and utilization in your work. So while some of the categorizations here that I've listed really may be subject to debate, and the idea is for us to get a sense of what you see as being vitally important to maximize PrEP uptake among the communities you serve. So either individual factors, interpersonal factors, community factors, institutional factors, or financial factors. And we've added an all of the above option, but would really love for you to think about that one facilitator that stands out above the rest in your HIV prevention work. Oh, great. Okay, so I think this very much aligns with all of our thinking here. That we certainly need to maximize facilitators on multiple fronts, including widely available and practical financing mechanisms to ensure sustainable access. So with that, next slide, please. Okay, so jumping right in, we get to the heart of the matter here, and that is that PrEP can be and often is associated with significant cost. So what I've included here are some cost estimates for the most basic PrEP services. These come from an informal analysis of claims data and fee schedules and reflect a range of per service costs. And highlighting a few things quickly, I'll note that generic TDF-FTC, or the generic version of Truvada, is actually costing pharmacies less than $20 a month, but its cash price at the pharmacy counter can vary substantially due to the fact that most pharmacies are operating in an insurance payment model, which may yield significantly higher reimbursement rates and don't necessarily have separate cash paying pricing for when insurance isn't available. And as you can see here, the monthly list prices for branded TDF, FTC, and TAF, as well as injectable cabotegravir, are considerably higher than that for even the highest cash price for generic TDF, FTC. And we also have estimated costs for standard antigen and antibody testing, PCR testing, which is recommended every 2 months by the CDC for injectable cabotegravir, creatinine testing for tenofovir-based regimens, and human chorionic gonadotropin testing for adolescents and adults with pregnancy potential. Click, please. Next slide, please. Okay, so depending on the different configuration of the services that we have here, annual costs can range from $700 to more than $25,000. And something that's very important to note here is that recommended STI and viral hepatitis testing are not included in these estimates that I provided, nor are important ancillary services such as navigation services or transportation. I'll also add that even at the lowest possible estimated cost of $700, this can be prohibitive for many low-income individuals vulnerable to HIV infection. Next slide, please. Okay, so to provide some context for PrEP financing mechanisms, I wanted to provide sort of like a quick snapshot of those available for HIV care and treatment for people with diagnosed HIV infection, which in some ways represents the closest we've come to universal, albeit highly fragmented, healthcare in the United States. So we have employer-sponsored plans, we have federal and state Affordable Care Act marketplace and off-marketplace individual plans. We have Medicaid and Medicare, which are two of the largest payers of HIV care and treatment in the U.S. We also have the Ryan White HIV/AIDS program, including age drug assistance programs, along with manufacturer and charity patient assistance programs for low-income individuals and cost-sharing assistance programs for insured individuals. Next slide. Okay, so one very important thing to note about the different Ryan White parts is that they not only provide comprehensive medical and support services to low-income people living with HIV who are uninsured or underinsured, but also can provide wraparound support for those who are insured. And these include premium payment assistance and cost-sharing assistance to help limit out-of-pocket spending as a barrier to insurance coverage for HIV care and treatment services. And all of this likely helps to account for significantly higher virologic suppression rates among people living with HIV served by the Ryan White HIV/AIDS program, compared with the national average among people with diagnosed HIV infection. Next slide, please. Okay, so when we take a look at the HIV prevention and PrEP payer patchwork, a major gap is readily apparent. There's effectively no federally funded safety net for people vulnerable to HIV infection with low incomes. Specifically, there's no federally funded program to establish comprehensive clinic services or medication access for those unable to access public or private insurance, and no federally funded program to help defray out-of-pocket costs for those with insurance. Now, one thing I neglected to mention in my previous slide is that approximately half of all people living with HIV receive at least one service from a Ryan White provider, with roughly 25% receiving support from the age drug assistance programs. And one very important thing to remember here is that the only thing that differentiates people living with HIV from those vulnerable to HIV is an HIV diagnosis. And so people vulnerable to HIV experience the exact same structural barriers to services, including affordable medical services, support services, and insurance. Next slide, please. Okay, so this slide doesn't really do justice to the complexities of public and private insurance coverage of PrEP services in the US. But generally speaking, at least one medication option for PrEP is being covered by most public and private payers nationally. Now, not surprisingly, many payers and their plans are preferring generic TDF-FTC over the costlier brand name products. And what we often see are prior authorization processes, often with clinical criteria, as the form of utilization management that's being employed. So with both oral and injectable versions of PrEP available, different coverage types are often at play. With the oral tenofovir-based products almost always covered as a pharmacy benefit, and cabotegravir often being subject to medical benefit coverage, which can affect the ways in which the drug is procured, the way it's associated with different prior authorization requirements, and is associated with both drug product and provider administration costs, including insurance cost-sharing requirements. Also, labs associated with PrEP are generally covered by both public and private plans. And one important thing to note here is that cost-sharing requirements, including deductibles, copays, or coinsurance, have historically been significant expenditures for people vulnerable to HIV, and consequently have been a significant barrier to clinic visits, labs, and medication access. Next slide, please. So this brings us to the importance of the evidence-based U.S. Preventative Service Task Force Grade A recommendations for PrEP. So not only does the recommendation reinforce advice to clinicians to offer PrEP to all individuals indicated for PrEP based on CDC guidelines, it effectively requires most private insurance plans and Medicaid expansion programs to cover PrEP services without cost sharing, in alignment with provisions in the Affordable Care Act, which, by the way, was signed into law 13 years ago yesterday. So up top is the first USPSTF recommendation that was finalized in June 2019. Below is the draft recommendation summary, which is actually based on an expanded evidence review of the different PrEP modalities that are now approved by the FDA, which was released in December 2022 and is expected to be finalized this year. Next slide. Okay, so and based on the first recommendation finalized in 2019, numerous public and private insurance plans available to people vulnerable to HIV infection were required to cover PrEP without cost sharing by the end of the year 2021. Next slide, please. Okay, so one very important facet of insurance implementation of the no cost sharing requirement is the understanding that PrEP isn't just a drug, but rather a compendium of services that must be covered, including HIV testing, safety labs, STI screenings, adherence supports, and yes, the medications approved for PrEP, including no cost sharing requirements for branded medications where they are clinically indicated. Next slide, please. Okay, so in addition to federal policies from the HHS Centers for Medicare and Medicaid Services, ensuring that PrEP as a comprehensive service is recognized by payers, many state insurance commissioners, sometimes with the backing of state legislation, have held commercial payers accountable to cover and $0 cost sharing requirements, with one example being this notice from California's insurance commissioner from 2020. And in a few minutes, Kenyon is going to talk to PrEP for All's work in holding payers accountable and actually holding CMS accountable to both federal and state requirements in association with the Grade A recommendations from the USPSTF. Next slide, please. Okay, so for those who are uninsured or underinsured, medication assistance programs, also known as patient assistance programs or PAPs, are available from both manufacturers of the brand name products that have been approved by the FDA, along with the federal Ready Set PrEP program involving Gilead's PrEP products. Now, the manufacturer assistance programs for uninsured clients, and in the case of these programs, some insured clients generally require that incomes not exceed 500% of the federal poverty level, which is around $73,000 for an individual in 2023, whereas the Ready Set PrEP program does not have a specific financial, it does not have any specific financial requirements. And while all programs are undoubtedly helping to ensure access to PrEP medications, they cannot be used to defray the clinical and laboratory services. Next slide, please. Okay, so for insured clients, manufacturer cost-sharing assistance programs can be used to defray out-of-pocket costs associated with PrEP medications in most states, including the administration costs associated with injectable cabotegravir. Now, there are no income thresholds associated with these programs, though there are important limits as to the cost-sharing requirements these can be applied to, notably Medicare out-of-pocket costs. There is also the Patient Advocate Foundation, which is effectively a charity that is supported with industry funds, that can be used to defray out-of-pocket costs, via reimbursement mechanisms, effectively for any PrEP drug, including generics, and for pretty much any insurance type. However, here, there are financial eligibility criteria. Next slide, please. Okay, so in the absence of robust and federally funded safety net for PrEP, we do have a number of state PrEP assistance programs, approximately 14 in total, with varying levels of support for things like cost-sharing assistance, medication coverage for uninsured and underinsured individuals, and clinic and lab costs, as well as cost-sharing assistance. And I would certainly encourage everyone to, to visit the link that I've referenced at the bottom, to learn more about these incredibly innovative state-level initiatives that are, in many ways, effectively leveraging things like Ryan White and ADAP infrastructure to help to meet the needs of people vulnerable to HIV. Next slide, please. Okay, and one program that may be of particular interest to many of you participating today is California's assistance program for both PrEP and non-occupational post-exposure prophylaxis, which involves a number of comprehensive clinical and prescription drug services. Next slide, please. Okay, so in thinking about a national PrEP plan and what this might look like, it's really important to understand that while there are currently a number of federal grants that can be used to support HIV prevention activities in the US, they are limited not only in the awarded amounts that actually reach service providers, but also in their usage allowances. So as you can see here, for example, the vast majority of federal funds cannot be used to purchase PrEP medications, with many of the grants effectively disallowing PrEP prescribing, even if the medications are to be covered by another payer source. So a limited patchwork of federal funding streams to support our HIV prevention safety net really at best. Next slide, please. Okay, so in the absence of robust federal funding and insurance coverage of important support services, many HIV prevention programs are reliant on revenue or program savings made possible with the 340B drug pricing program. So to describe how 340B works here, let's use the example of a drug with a hypothetical list price of $1,000 a bottle. Next slide. Okay, so using the same formula to determine manufacturer rebates that must be applied to prescription drugs covered by Medicaid, 340B covered entities, and many PrEP programs are 340B covered entities, or at least co-located within a 340B covered entity. So these 340B covered entities receive a minimum 23.1% discount off of an average price that approximates the list price for the drug. And every time the drug price increases at a rate faster than inflation, and this has been very common among all branded HIV drugs, additional discounting is required. So here we're visually indicating a discount of around 60%. So 23.1% plus additional inflationary discounting, which is not uncommon, particularly for brand name drugs that have been on the market for several years and have been subject to multiple price increases. Next slide. Okay, so while the 340B discounting enables 340B programs to purchase the medication for eligible insured clients at a discounted price, again, let's put this at around $400 after a 60% discount. it will be reimbursed by most insurers at usual and customary rates, so perhaps $75 above the list price for the drug. So in this case, a difference of at least $230 can be expected, with the illustration here being around $675. Next slide, please. And so what we see here are the net medication cost of the program and the program savings for the program per bottle per client. So while contract pharmacies and other middlemen involved in the process may require some percentage of those program savings, the net revenue for programs can be significant and vitally important, on the order of hundreds of thousands, if not millions of dollars generated annually. Next slide, please. Okay, so this is just a snapshot of the types of services that 340B program savings can support, with these examples out of Thrive, Alabama, which is one of Alabama's most important HIV care and prevention providers in the state. And these 340B funded services not only benefit uninsured individuals, but also insured clients requiring additional care and support. Next slide, please. Okay, so for the sake of time, I'm not going to go into everything listed here, but do want to stress that there are a number of factors that have resulted in and continue to result in significant declines in 340B program savings for HIV prevention programs over the past few years. And these ultimately do call into question the future of 340B program savings as a truly sustainable primary source of financing to not only maintain, but also expand comprehensive PrEP service delivery in the United States. Next slide, please. Okay, and so with that, I am going to turn it over to the amazing Kenyon Farrow, and I will thank everyone and look forward to your questions during the Q&A.
Thank you so much, Tim. Good to be here and good to be participating with several of my longtime colleagues in different iterations in this work. So I'm going to share my slides. So we will get started in 1 second. Let's see. While I'm setting up my, here we go. My slides here, we can go ahead and move to the poll question. So a little, fun and trickery here. So my question for y'all is, which of these statements is mostly true? So number one, people with private insurance can now easily access PrEP with no cost sharing. Two, insurance companies are doing their best to adhere to federal PrEP cost sharing regulations. And three, new court challenges may undermine PrEP access for even insured populations. All right, so I'm not going to answer this question right now, but we're going to kind of go through this presentation and hear parts of this. So thank you. But a majority voted for the final, the last decision. So first to start us off, just to talk about, where we are in terms of the question of PrEP and financing and what costs would mean. And I think first and foremost, something I've been saying to people for a while is, the cost, because a lot of times I have found in, kind of discussing, pricing and PrEP financing with some advocates, I often have gotten sort of pushback that, oh, we have, cost isn't the reason why, communities, specifically communities of color, Black and Brown communities, are not adopting PrEP more widely in the way that we see amongst particularly, white gay and bisexual men. But part of my sort of pushback with that is that first and foremost, that cost influences the entire system, from, upstream to down, right? And so there are elements of the way in which, particularly for the first 10 years of PrEP's, entrance into as a prevention intervention, a number of different sort of programmatic, systems were impacted by cost downstream. That's number one. The second thing is, even before, TDF-FTC was approved for PrEP in 2012, there were concerns already being raised in the literature around costs, right? And what it would mean in terms of the sort of public health impact of PrEP's availability. So in this first study from 2008, right, 4 years before the FDA approval, this study, kind of closed with, in summary, we found an HIV chemo prophylaxis program, right, or PrEP as we know it, could be reasonably effective at reducing the number of new HIV infections and quite cost effective over a broad range of epidemiological, programmatic, and cost variables, right? So already, 4 years prior, beginning to think about, the cost effectiveness of PrEP. And secondly, this study from 2011, further research must be performed in non-clinical trial settings to evaluate the real-world efficacy and cost effectiveness of a PrEP strategy. Delaying action on these cost reduction and awareness measures is not only irresponsible from the standpoint of public health, but also restricts important preventative care from those who need it most, right? So even, again, before, we saw the first drug roll out onto the market, these papers, researchers were raising the question about, how we were going to deal with the question of cost. So first and foremost, I'm not talk so much about prior authorization. Tim, kind of mentioned it as one of the barriers, I think, particularly in the first decade of PrEP. Those, payers have reduced the number of the sort of burden of prior authorization in situations where they are, kind of encouraging people to be taking the generic TDF-FTC unless there's a, kind of a medical reason for folks to be on FTAF, or I guess now the injectable long-acting CAB as well. But we know that, prior authorization is a challenge. So I know my other presenter colleagues, and some of you who have probably heard me tell the story before, when I started PrEP in 2015, I was, basically told, okay, you can start PrEP after all my testing came back. And, doctor or the nurse asked where I wanted the prescription to go to. I gave them the, pharmacy I was using closer to my house. And before I left the building, the nurse called my phone and said, hey, we can't, the pharmacy called and said, hey, we can't fill this prescription, right? So I went back to my doctor's office, spoke to the nurse. She tried to get it filled at the pharmacy in the building. I went down there, waited, they couldn't fill it. And that was my introduction to the issue of prior authorization. And essentially at that point, I was forced into the specialty mail order pharmacy with my insurance company, which was a hassle for me because as many of us in this work travel a lot, trying to sort of schedule when the medications would arrive, when I was, out of town or this, that, or whatever was a challenge. And I was also, I was 40 or 41 at the time when I started PrEP, 41. And so I was able to, kind of manage and also do a lot of self-advocacy at that point that made me really wonder what would happen to, 20-year-olds who were also trying to start PrEP, and if they would be willing to go through days and days of trying to figure out how to get this script filled without going through a pharmacy, and if they just would have given up, right? So this is, part of, one of the dynamics, right? Folks are certainly aware that, co-pays could be a problem, for folks, whether for doctor visits or for copay medications. Early on, my own copay for a long time was $50 a month, which again, I was lucky enough to be able to afford, but many people can't, and if you have a high deductible plan, then, you still have other challenges of what you have to do to sort of pay out of pocket before, your insurance kicked in. Talked about being forced into specialty mail order pharmacies. Right. And this study from 2020 essentially, details like some of these issues. So among 16,853 qualified health plans in this cross-sectional study, the proportion of qualified health plans in the South that required authorization for PrEP was 37% compared to 13% in the Midwest, 6% in the West, 2% in the Northwest. And if we know what we know, just one about where people are most vulnerable to HIV geographically, also, racially, most people of African descent in the United States still live in the Deep South. And that is where, we were still seeing, at least in terms of this study from 2020, challenges with prior authorization still being used, right? There's a study. So just, at the end of the day, a lot of these different kind of systems end up with, access denied for many people. So when I was the senior editor at thebody.com, the first piece I edited was this piece, which describes part of the problem. This was from late 2017, where talk about pricing issues, the responses, oh, we have copay cards, we have patient assistance programs or whatever. This story that I edited basically sort of detailed where this didn't work. So this person, Giuliani, who wrote the story, as a personal story from California, tried to get PrEP, but had to enroll in Medi-Cal to, get access to just healthcare generally, and obviously to get PrEP. And so in the time that he was waiting for the Medi-Cal enrollment to kick in, he started just procuring PrEP meds from friends and partners. And all the while, they had a PrEP navigator who never told them about the patient assistance program, right? At the organization they had approached. And so they ended up running out of PrEP and, couldn't procure, and ultimately was diagnosed with HIV some weeks after getting their last pill that way, right? So this is just to say that, like, those programs can certainly be of help, but for the people who don't get them, they don't, often work. So a little bit about the work I was doing when I was still the managing director of advocacy and organizing with PrEP for All. So as Tim mentioned, in 2019, the USP, U.S. Preventive Services Task Force, gave an A rating to PrEP. And then in the summer of 2021, the Center for Medicare Medicaid Services and the Department of Labor issued a joint kind of FAQ to say that if you are receiving, PrEP and if you're on PrEP and you have a employer-based or an ACA marketplace plan, that, those plans had to cover, PrEP, as a program, right? So, the medications, the labs, the visits, all the things that Tim also outlined at no out-of-pocket cost to the patient. This flyer is from, kind of Zoom event we did with some federal leadership on this issue to address the issue. And so what we did after this conversation was launch basically a Google form that we created and promoted across social media, and asking folks who were on PrEP to tell us if they were still being charged medication, if they're still being charged, co-pays or lab expenses, et cetera. And, for us to then, kind of figure out how to deal with it. One of the challenges with this system is that there's no enforcement mechanism. So despite the ruling being in place, there was really no way for, people to have any kind of redress other than going through the normal, you're going through your insurance company and, trying to refile a claim for coverage. Which a lot of people just don't know how to do or don't have the time to do. So when people were getting those bills, they were struggling to try to figure out how to fight them. So with this monitoring project, what we ended up documenting was about 100 people on PrEP who, some portion of their services weren't covered. So one of the things I did was basically create a form letter and then try to look up all of the mailing addresses of top the CEOs at these various health companies. to tell them that, hey, we have documented cases of patients under your plans that are not, that are still paying out of pocket. I would give them some detail about what, on average, based on the number of people who were in a specific health plan, what the average sort of expense was and what it was for, and then refer them to the, the CMS and Department of Labor FAQ. Most of those companies, several of them got back to me, but just gave me a bunch of word salad and didn't really address the issue. There were a couple patients that I communicated with who were able to get reimbursements. I also gave them, all of them, kind of copies of the form letter so they could also use it themselves to try to get reimbursed. So one of the things that we sort of looking at, that just small set of data from people who filled out the survey, that the most, kind of egregious cost was for labs. I mean, and sometimes those labs were in the $300, $400, $500, $600 level that people were being, stuck with. And sometimes the labs was sort of a tricky thing because, folks were sometimes told, oh, the labs, the company where you got your labs taken was not in network, right? And I think many of us have had the experience of, going to a lab and getting our blood drawn or giving samples one day, and then, your insurance company decides that they're not contracting with that lab anymore, and you still go there because that's what you think, and then find out that you're not covered and then end up with a bill. So, these are some of the issues that were happening to folks. What ended up happening was finding out about the work that we were doing, I think largely through some of Jeremiah's leadership on kind of educating folks in Congress about, the national PrEP program for uninsured folks. We got, an email from Senator staffers at Senator Merkley's office, and Senator Merkley with several other senators sent a letter to AHIP demanding answers for insurers not, following the ruling. And gave them 30 days to respond. AHIP ended up responding, essentially saying that they didn't, determine that it was a quote unquote widespread problem. And where it did happen, it was a misunderstanding by providers on proper coding, right? But also didn't tell people what coding to use. So, these are the kinds of challenges that folks faced. So just in closing, to just talk about what some of the, kind of new challenges are, right? So we know that the higher cost, as Tim pointed out, of FTAF means that, PrEP users who are, using that particular medication are still dealing with some of these cost containment measures. A few pharmacies, I remember just some discussions last year, we're still actually, billing public health programs or other places still $1,800 for the generic TDF-FTC in some states. So, and again, there's no, accountability there. Long-acting CAB is a great option for people, but some of the same payer and coverage challenges exist. And then, of course, there is the Texas lawsuit that is, moving through the Supreme Court, which could gut the power of the U.S. Preventative Services Task Force and the ACA law based on, religious objection, right? Which is to say, homophobia, sex negative politics get to shape access to care, right? So, we're going to see what happens there. And then also, I think a sort of somewhat tangential issue, but I think is important, is at the end of Roe v. Wade, has threatened sexual reproductive services, particularly for cis women, but, a range of other folks who often use a Planned Parenthood or those kinds of organizations, oftentimes where there is no other, care to get, sexual and reproductive, care services, end up losing out because those clinics are closing in states around the country. And so in addition to just not having access, to abortion or contraception, losing potentially access to PrEP services, particularly in, smaller towns and rural places where, that sexual reproductive health clinic might be the only option in town. And so with that, I will just say thank you, and I will pass it over to my pal, Jim Pickett, who is a senior advisor at AVAC. Thank you.
Great. Thank you so much, Kenyon, and thanks to the organizers for being here, and a special shout out to my fellow Chicagoans who are in the room today. I also am a control freak, so I'm going to share my slides myself. There we go. And let me just minimize all these other little screens so I can see what I'm doing here. Give me 1 second. Okay, I'm going to just hop right into it. I'm going to be speaking about PrEP equity, but really when we talk about PrEP access in the United States, it's all about inequity. But first, a couple of framing comments. I love this slide from Dr. Sevic, who presented at CROI last year. This was in reference to COVID, but it certainly fits the HIV context as well. People are not the drivers of transmission. Rather, it is their unmet needs. And you see all those little lovely icons there. Those icons basically point to the social determinants of health. And we know this slide very well. We could spend the next several hours, days, weeks diving into all of the issues in this slide, but we know if we're not meeting people's social determinants of health, if people don't have access to food, if they're housing insecure, if they're unemployed or underemployed, et cetera, their access to care falls right down the toilet. And of course, I need to say, our system here in the United States is based on racism, where everything we do is racism is baked in, and our public health system, much of our problems are because of the systemic racism that is baked into the cake and the white supremacy that is a part of it all. So folks who are familiar with AIDSView, if you're not, I would definitely check out AIDSView. It's a great place for lots of metrics and data. They are tracking PrEP uptake and PrEP numbers. But outside of the numbers, so we can see numbers increasing and think, yay, we're really doing good. Look at us. The numbers are getting more and more people around PrEP. But this number here, really speaks to equity and inequity. And this is a concept that was put forward by Dr. Patrick Sullivan and some of his colleagues called the PrEP to need ratio. So what this slide is showing is the 2021 PrEP to need ratio as being the ratio of the number of PrEP users in 2021 compared to the number of people newly diagnosed with HIV in 2020. So if you look, I highlighted a couple of things helpfully there for you. The lower the number, the higher the need. And you can see quite clearly where we have very low numbers by race and by gender and by age. Patrick has done more work around this. I was just on this webinar a couple of weeks ago that was put on by Harvard CFAR around the use of local PrEP equity metrics. I highly recommend watching it. It was brilliant. He goes into equity and then he formulates another concept that is that pairs up nicely with the PrEP to need ratio, and that's the PrEP inequity ratio. And I would highly recommend checking that out. And a little self-serving thing here. I run the choice agenda for AVAC. It's an ongoing webinar series, and we're going to have Patrick on a webinar in early May with two rock star PrEP advocates who are really leading the work that's called PrEP in Black America, Leisha McKinley Beach and Michael Chansley. Leisha is an advocate on her own, and Michael works for PrEP for All. So I highly recommend checking this out. We'll have more discussions with Patrick about what this PrEP inequity ratio is and how we can do better around PrEP equity. And that link down there is where you'll find the login information or the registration information when it's ready to go. It's not ready yet. So I have 3 questions for you. And my first question, or we can launch the first poll, is this. And it's just a simple true or false. In a big win for generics, the vast majority of people taking PrEP in the United States are being prescribed generic TDF-FTC. Is that a true statement or is that a false statement? And then let's see those results as soon as they're there. This should be quick.
We're at about
One or the other.
56%, 57.
All right, come on. 75 is the magic number, right?
Okay. 61.
The tension is unbearable. True or false? Which one?
All right, we're at 65. How about that?
Okay, we'll take it. So 40% true, 60% false. Thank you for engaging. I'm going to show you a little data now. And that helpful red box, this is from a poster that was presented at the CORI 2023 conference, happened a couple of weeks ago in Seattle. And you will see that generic FTC TDF is the most prescribed, but it is not by far a majority. It is 50.3%. A huge chunk of PrEP prescriptions are for Descovy or FTC TAF. You see a small number of brand name Truvada prescriptions in there, and then a tiny, tiny, tiny number of cabotegravir long-acting or Apretude. And it's just, Apretude is so hard to get. It is so complicated that very few people are willing and able to jump through the many, many hoops that our friction-full system makes people jump through. But I want to really interrogate here is what's going on with Descovy? Like, why is it that so many of our prescriptions, almost half, are for FTC TDF, FTC TAF? Let me just say TAF. I think I screwed that up a couple of times. But before I get to that slide, just reminding you, I mean, Tim showed a little generic costing before, but a generic bottle of Truvada, TDF FTC, is 17 bucks and change for a bottle of 30. If you go to Jewel here in Chicago, you can get that bottle for $35. But as Tim noted, generic prices are very, very high. I also noted that Walgreens and CVS in Chicago, generic TDF FTC was around $500, so quite a shocking difference. But we're going to dive into the second question that I set up earlier. And this might take a few more seconds than the first one. So if we can launch this poll, what are the reasons for the large percentage of Descovy prescriptions? You can check all that apply. Descovy is a better, safer version of oral PrEP. Almost half of PrEP users are clinically indicated to take Descovy or TAF over Truvada TDF FTC. Pharma is going to pharma. And your last choice is 340B creates perverse incentives.
All right, we've got 71%. I'll share those results.
Yes, let's see those results. So interesting. So about a quarter thought that or agree with the statement that Descovy is a better, safer version of oral PrEP. A third think that half of PrEP users are clinically indicated to take Descovy. A lot of you are also saying pharma's going to pharma, and a lot of you are noting perverse incentives. So we're going to definitely talk about perversion in a second.
I think John.
So we're going to. So yeah, so we're good. So first of all, I just want to share some background here. You can read this lovely quote from Gilead's chief commercial officer in February 2020, really speaking to their strategy for switching everyone who is on Truvada for PrEP over to Descovy for PrEP. And they were getting ready for Truvada to go generic. And they were working closely with their prescribers to make sure their patients get the most appropriate compound for them. Well, guess which compound Gilead thinks is the most appropriate? It is the new drug, the name brand drug. It is not the drug going on generic. So you saw at that time, and still to this day, all kinds of materials, updating your PrEP, like your old PrEP is old news. You need to have the new, fresh, wonderful PrEP. And that picture on the left, I have disguised that person lovingly. I didn't want to, belittle him on this national webinar, but this was from someone I followed on Instagram when this all happened, and it's a doctor here in Chicago who was happy to show the new Descovy, to say, yes, everyone should be on Descovy for PrEP, Truvada for PrEP is not the right choice. And I'll just say, I commented on his Instagram post there, and I was promptly blocked. So you can maybe guess what kind of comment I left for them. So this led to all kinds of drama, which many of us can remember, and some of that is still going on. So this idea of ambulance chasing lawyers and class action lawsuits about TDF FTC being a dangerous drug and scaring the hell out of all of our communities, blanketing our Facebook feeds, our Instagram feeds, all our social media. I still see this on Instagram. I've resigned from Facebook. I still see this crap on Instagram. And all of these things driving this narrative that Truvada is not safe or bad. And Gilead really helped foment that by saying, oh, we have this newer, safer, better version. Everyone should be going to that. So they actually, while it may seem like they were being taken to task by all these lawsuits, this actually helped build their market share. This helped scare a lot of people into demanding to be on Descovy, going to their doctors and yelling at them for putting them on something quote unquote unsafe, etc. So this was a hot mess. I'm sure many of you remember. And we had to fight back against this. So that middle thing is Truvada safe. When I was at AIDS Foundation Chicago, we created a flyer and some materials with that. And long story short, Truvada is safe. It's safe and effective. And it's perfectly acceptable for the vast majority of people who need to be on PrEP. But it took a lot of energy, right? So we had to push back in every way we could. Activists went after Facebook for pushing misinformation. Positively Aware did a story, Pause did a story, The Body did a story. A number of organizations put out fact sheets about this, saying, hey, Truvada is not the devil. Truvada is completely appropriate for most people. Your kidneys aren't going to fall on the floor, your bones aren't going to break. When you're on PrEP, you're clinically monitored. But it took, once that genie's out of the bottle and all of that negative poison is out there, it's really hard to clean up. And I think some of this is why we see such high numbers for Descovy. There was a commentary in The Lancet, again, pushing back and saying these advertisements promote false information about the safety of PrEP by suggesting that rare side effects, such as renal failure and bone loss, substantial bone loss, are commonplace. This is a letter that our health department in Chicago put out. So it was all after the fact, all having to clean up this huge mess that really served one entity and one entity only. Who was it? Gilead. Now, I hope I got your attention with this slide that says perversion. This is maybe not the perversion you were looking for, but this is an excellent article. I highly suggest reading it, called Perverse Incentives, HIV Prevention in the 340B Drug Pricing Program. And what I'm getting at here and what this article is getting at is what a lot of you also noted in that poll, is that when we have 340B that prioritizes name brand drugs, there is a perverse incentive to prescribe name brand drugs. You're not going to get big rebates with generic Truvada, so move your patients over to Descovy, whether or not they clinically indicate that. And I personally have a real issue here. I know it's hard as a FQHC in a community health center to get the kind of funds you need to do the kind of work we all need to do, but are we prescribing for individuals or are we prescribing for programs? So just to point out a few things in case you didn't know and to share some resources, this is a really great fact sheet that Howard Brown Health in Chicago put out a couple of years ago during all of this when Descovy came out. And it really lays out the differences between Truvada and Descovy. But the end of the story is they're both safe and effective, and that side effects are different. So while Truvada has the rare risk of stress on kidneys and bone loss, we also see potential weight gain and increases in cholesterol from the Descovy side. Now, I bet you don't see too many Descovy ads talking about potential weight gain, do you? But it is a fact. It's been borne out by science. Otherwise, these drugs are pretty much similar. I will say, however, that Descovy was not tested amongst cisgender women, so it is not. We cannot prescribe that for people who were assigned female at birth. We have no idea whether it works in terms of vaginal exposure. And I think this was also on purpose by Gilead. They tested it among the population where they were going to get the most bang for their buck. And the most bang for their buck is going to be gay men in the United States, and you can go further and say middle-aged gay white men with really good insurance in the United States. The rest of the world is not paying attention to Descovy. The rest of the world has been using generic Truvada for a very long time for treatment, and the rest of the world is using generic Truvada for PrEP. So I want to highlight that last little that bubble over there. The vast majority of people who are clinically indicated for PrEP or who could benefit from PrEP can be prescribed Truvada with no problems. So anyone who says differently, you have to wonder what Kool-Aid they're sipping or whose water they're carrying. And I'm gonna say it's not just crazy wild-eyed advocates like me saying this, but in the Annals of Internal Medicine a couple of years ago, there was a number of articles that came out that drive this point home. Given the available clinical evidence and public health context, when people think of PrEP, they should still think of TDF-FTC. You can recognize all of those authors there. Here, the first author is currently heading up the CDC. And she made this comment in AIDS Map in an interview. It's not necessarily from the article, but she said in AIDS Map, TDF going generic presents us with an amazing opportunity to get more people onto this effective prevention method, and especially the poor people who need it. In HIV, we have a history, for very good reasons, of preferring the shiny new drug over the old one. But in this case, the old pill is safe. And it would be tragic if access to prevention was blocked by drug companies capitalizing on the profit potential of a new pill. Well, that is exactly what's happening. And here's yet another article saying basically the same thing from two more highly respected leaders in the HIV fights. My third and final poll question, and then we're going to bring it home. So the question is, because injectable cabotegravir for PrEP, name brand Apretude, has been shown to be quote unquote superior in clinical trials, it is increasingly unethical to prescribe folks oral PrEP. Do you mostly agree? Do you mostly disagree? Or are you like, huh? So most of you say, disagree with that statement, and a good chunk of you are like, huh? Is that even a thing? So thank you for your feedback on that. We're in the home stretch here before I turn it over to my wonderful colleague, Jeremiah Johnson. I just want to, as you take in what I think is some key elements of what ethical PrEP is, I just want to challenge this idea of superiority. Now, we know that cabotegravir long-acting in clinical trials was shown to be superior to oral TDF-FTC. But superiority is a term that we use in clinical research. It does not have meaning in the real world. It is not, there's nothing, cabotegravir is not superior in the real world. Let's be clear, Truvada, 99% plus efficacy if you use it consistently and correctly. The vast majority of people who use it consistently and correctly will never test positive for HIV. And cabotegravir was more effective than even something so effective. And a lot of that was because of adherence and, and knowing it. We knew whether people were adherents or not. When people got a shot, it's reported. It's not up to someone else. It's not up to you to give yourself a shot. Someone else gives you that shot. So I want us to be really careful when we're talking about PrEP and when we lay out PrEP options for people, that we don't use words like superiority or this is the superior option. The superior option, the best option for someone is the one that they're going to use and the one that they can use consistently and correctly, period. It does not have to do with efficacy results in a clinical trial. So if we're going to do something great here, all sexually active people are educated and offered PrEP. All sexually active people are offered choices. People get to choose what's best and get to change their minds. When we're thinking about public resources that have not been distributed equitably or equally, they are prioritized for the most in need, that we spend our scarce public resources wisely and focus on generics, and that we create services that are easy and breezy to get, easy breezy to start, easy breezy to stop, and easy breezy to restart wherever you live, whoever you are. Wouldn't that be beautiful? Just like Zendaya here, easy breezy, beautiful cover girl. Now I know they changed their, their tagline, but this is from the 70s. I still love this tagline. So I'm going to wind up here with what I would like to point out is something we should all be working towards is PrEP justice. So we know we're all against inequality, boo, PrEP inequality, not having that. But equality also sucks. Equality means that everyone gets the same tools, but the system is rigged in a certain direction and helps certain people and doesn't help others. So the same tools does not really help you get on to PrEP or whatever you need, right? So I'm much more in love with this idea of equity, where you get the appropriate tools to get to be able to pick those apples from the tree or pick your PrEP. So you have differential ladders, but you can see that the system is still rigged. The system is still flawed. White supremacy and racism is still doing a number on that tree. So this is what we should be going for, justice. We should be fixing the system. We should be readjusting the ground and providing all the support so the same tools can be used by everybody to get what they need. So I want to thank you so much for your time. I am going to stop sharing my screen and turn it over to bring us home with the fix for all of this, Jeremiah Johnson from PrEP for All.
Great, thanks, Jim. Okay, we're almost there, everybody. A lot of great information, great presentations. And thanks for sticking with us. 117 people in this discussion on a Friday really shows the power of PrEP and how much this really matters to people. So I'm going to encourage us all to just take a deep breath through the nose and out through the mouth. And we're going to focus in on this final presentation, and we're going to be very zen about it. To Jim's point, we don't want to leave everybody with just the problems. We want to talk as much as we can about the solution going forward, because that's what our communities deserve. Our communities deserve fair access that gives everyone a fair chance at actually being able to access PrEP. This is something that is of personal importance to me because I was diagnosed as HIV positive back in 2008. And I would have given anything to have something like PrEP in order to avoid HIV. Back at that time, I just believed that it was inevitable. And ultimately, I did end up getting HIV. And so part of the passion that I have for this work, that I know is the passion that Kenyon and Tim and Jim have, is it's so heartbreaking that we are not doing better to get PrEP to the communities that need it the most right now. That people are still having to center HIV so much in their daily lives. The other thing I like to bring to the conversation is that I have a long-term relationship with someone who's HIV negative and who has been on PrEP since 2012. And so for me, this also, beyond delivering peace of mind to our communities and finally ending HIV as an epidemic, PrEP for me is a love story. Because it's hard enough to find somebody that you want to connect with in your life, let alone live with, and have to make space for a virus as well. And so for us, that really allowed us to be able to take the virus out of the conversation between that and U equals U. And so I just like to bring that personal context into all of this, because I think we get into all of these policies, we get into all of these programs, we get into talking about pills. But at the end of the day, we're trying to end HIV as an epidemic for our communities and deliver peace and love to our communities. And that's what drives me in terms of what we're talking about here. So the solution that we've been talking about in community for almost 2 years now is calling for a national PrEP program. And I'm going to get a bit into what we mean when we're talking about that. Next slide, please. Just briefly, Jeremiah Johnson, pronouns he, him, and I'm the new executive director here at PrEP for All. Also, I was a co-lead on a paper and proposal out of Johns Hopkins University that has helped to inform this conversation as well. My email's there, and I get to work for a really great organization, small but mighty, that's focused on a national PrEP program called PrEP for All here in New York. Next slide, please. So what I think you really see in the presentations from Tim and Kenyon and Jim is that while we have many amazing champions trying their best in complicated circumstances to get PrEP to as many people as possible, what we've done, all of our collective efforts and everything that we have done to this point is not working for those who need it the most. Of the 1.2 million Americans that CDC has estimated could most use PrEP based on risk factors, we're, as of 2020, only getting it to a quarter of those individuals. And while a quarter is already a terrible number, when you break that out by race and ethnicity, the story is even bleaker. We're maybe getting it to 66% of white individuals in that denominator, only 9% of Black and African American individuals, and 16% of Hispanic and Latinx individuals. Next slide, please. We also have enormous geographic disparities in terms of how this is scaling up, which is a big reason that we're calling for a national program. To many of Tim's points, there are innovative state level initiatives, but that's not getting it to everybody. And we need this map to look more consistent across, and to make sure that where you live in the United States isn't such a barrier to you being able to access PrEP. And it is really a theme across many healthcare fronts right now in terms of our communities. Next slide, please. So we're going to stop for just a second before I get into the solution, and we're not going to hang here too long because I realize that we do want to have some time for Q&A. But I want to take just a beat to hear from everybody. What are some of the barriers that, in your experience, are the biggest barriers in terms of accessing PrEP? And so I believe we can go to, this is going to be a word cloud. So you can type in 1 or 2 based on your attempts to get PrEP, your attempts to deliver PrEP, or perhaps just what you've heard on this webinar, and type maybe a couple of words, and we'll see where we get with that. Stigma, big one. Cost. This is great. Thanks everybody for participating. Awareness, excellent. Knowledge, absolutely. Cost and stigma, a couple of big ones keep popping up. And Greg or John, let me know when we've hit critical mass. Cost and stigma. Great. All right. If we're about there, we can move on because I know that we're also a bit low on time. But I think we get a message here that stigma and cost are at least a couple of the big barriers. So hopefully that comes through in the solution that we're proposing. I'm going to go very quickly through what we're talking about and really encourage everyone here to be an advocate for this. Because while we have a lot of momentum and we have a lot of great ideas and hundreds of advocates have put ideas and input into what we're talking about right now, we won't get anywhere unless we get the political will at the CDC, at Congress, and in the White House to actually translate this into reality. So earlier you heard a lot about insured populations and the USPSTF A grade that Tim and Kenyon talked about, and some opportunities there for you to try and share additional stories where you're seeing that people on insurance are still encountering barriers in terms of access to PrEP. This conversation is focused more on uninsured and underinsured populations. And I include this slide here just to show that that's not a small group. That's an enormous group. It's a critical part for us to cover if we're ever going to hit the public health level impact of PrEP scale up and truly end HIV as an epidemic. So over 30 million Americans are still uninsured. If you look at that cross section of people who are uninsured, they're going to be disproportionately Black, they're going to be disproportionately transgender. We're also going to see a lot of undocumented communities kept out of this conversation. Even if you have insurance, over 23 million Americans are still on so-called grandfathered plans that don't have to adhere to the USPSTF A rating. So those individuals are going to be underinsured. And as we heard earlier, even if you have insurance that is supposed to comply with ACA, doesn't mean that it's happening right now. So we really need a national PrEP program to fill in all of these gaps, because it's not just about access for the individual. We want to scale PrEP up to the point that we are actually driving down HIV, driving down new infections, so that our communities don't have to make space for this in the same way anymore, so that we can actually live our lives and address the many other horrible, political battles that are ahead of us right now. Next slide, please. So for the past 2 years, we as advocates, service providers, policy experts have been coming together to discuss how can we move forward in terms of PrEP equity. And we've been doing it in the midst of this unprecedented opportunity. So Tim talked a bit about drug pricing. What you see in this chart here is the point at which we had generic competition for generic Truvada or TDF FTC. And what you see with the green line is you still have that high cost per tablet for branded medications that continues to this day. You see a precipitous drop around April 2021 when we saw generic competition hit the market. And what has inspired us to come and talk about this is, as Kenyon referred to, when you're trying to move an incredibly expensive product, it makes it difficult for innovation. It makes it difficult for us to come up with advocacy messaging that's going to be effective for us to get Congress to invest dollars into a preventive service like this. So we have had an unprecedented opportunity having that price drive down. We can actually effectively, as advocates, go to Congress and talk about PrEP as cost savings for the healthcare system and think of innovative ways for scale up in a way that we wouldn't be able to through branded medications alone. Next slide, please. So within this context, there's a bit of a story here, and I'm just going to briefly go through some of the milestones, just to give everyone a sense of where the momentum is with this, and what are some of the next steps of what we're calling for. So this isn't, going to include everything that we've all been working on, but much of it started with PrEP for All back in July 2018, when the organization put out a white paper that called for the first time for a national PrEP program. A lot has happened since then, but the next milestone I'll take you to is following that entry of generic competition in 2021. I, along with a team based out of Johns Hopkins, began to convene experts, focus groups, PrEP users, everyone we needed at the table to start to talk about what would an innovative proposal look like in this context to finance and deliver PrEP to marginalized communities where people are uninsured and underinsured. Ultimately, that resulted in about 50,000 different versions that were typed up by Amy Killalay, who really spearheaded a lot of that project, and ultimately resulted in a final version coming out in December of 2021. That proposal caught the attention, along with a lot of existing PrEP advocacy from, the Federal AIDS Policy Partnership, where they've been working on PrEP bills in Congress to also call for funding for national PrEP access. And between all of that, we caught the attention of the Biden administration, where in his FY23 budget request, there was what they called a PrEP for All to End the HIV Epidemic program, a $9.8 billion mandatory program that would have gone over 10 years. And really elevating that proposal and really calling for everything that we've been talking about in terms of what equitable PrEP access should look like. Following that, we got into work with all of our colleagues within FAP and elsewhere in the national HIV policy space, and collectively came together as a national PrEP program working group to start and devise what is a feasible way forward for a program to be funded. At this particular time, and with a very divided Congress, getting a $9.8 billion program with mandatory spending through is challenging, to say the least. And so we came together and sent a request to Congress for a $400 million discretionary ask to appropriators to try and get us on our way toward a national PrEP program. And so we really catalyzed a lot of momentum around that. At this point, that coalition is over 120 organizations. We've had thousands of people sign on to letters for a national PrEP program, thousands of letters sent to policymakers calling for a national PrEP program. And so we really have a lot of momentum and energy and movement behind all of this. A key and important part of this was in September 2022. PrEP for All was proud to help convene the first PrEP in Black America Summit. This was a vision of Kenyon's, in particular when he was still at PrEP for All. And that brought together over 80 advocates in Atlanta, Georgia in September, that ultimately resulted in the release of a roadmap in February of this year, calling for steps toward PrEP equity that also called for a national PrEP program. Ultimately, this advocacy and this climate, we knew we weren't going to get the $400 million, but we did get a $25 million increase to CDC as a down payment toward a national PrEP program that we're hoping will inspire investment in a national PrEP program. So that pilot that we're talking about on this slide, and that gives us the momentum as we go to Congress again to try and press for additional funds in FY24. Next slide, please. So what are we asking for? It's one thing to ask for the money, but what are we going to invest it in? And hopefully what you'll see in the three buckets that we've sort of come up with what we want funded, you'll see that we are trying to get around some of that stigma that we're all concerned about, particularly within healthcare systems, and address those costs. Again, I can't take credit for these buckets. Kenyon came up with this particular categorization when he was at PrEP for All, and I gladly steal that from him. So one thing that we're calling for is a PrEP pass. We know as we've been discussing this entire time, that you're not going to get PrEP access if we aren't going to be able to cover the medication and the associated labs. It's simply too much of a barrier for individuals. I think from Tim's presentation in particular, you got to see that if you are uninsured in America, it's enormously complicated and fragmented for you to try and get coverage of all of those pieces based on what's available through CDC, through state level programs, through pharma programs. And so we're calling for something that cuts through all of that. And in particular, we believe that CDC is well poised as a federal agency to put all of this together into a PrEP pass that can be simply accessed by individuals, downloaded and used at a wide range of, wide network of national pharmacies and lab networks in order to simply cover those costs. So that's a big part of what we're calling for right now. We also want to open the door in terms of network expansion. Many people in our communities, they don't want to access highly medicalized situations. There's a lot of medical mistrust that is very understandable within communities, but many of those communities may be accessing services at places like LGBTQ centers, intimate partner violence shelters, homeless shelters, harm reduction centers, places where they have trusted relationships with individuals who might not be able to prescribe, but through leveraging teleprep, might be able to connect them to a prescriber, get them that PrEP pass, and then get them sent on their way to get labs and get access to that prescription. And so in this way, we're calling for investment in a grants program that would establish hub and spokes administrators within communities across the United States, where we can intentionally build those networks, where clinics that are already providing excellent care, providers that are already providing excellent PrEP care serve as the hubs, and where those folks can be a number of places within communities, including non-clinical sites where people are already accessing trusted services. It can also continue to act as a referral network for people who prefer to come in person to see a prescriber. And then finally, demand creation. We don't want to create an amazing PrEP pass, an amazing network, and then have people not know about it, have people continue to not know that PrEP is for them, that PrEP is highly effective. And so we want to make sure that we're coming with campaigns, but not just status quo campaigns. We want to make sure that these are campaigns that are working with PR firms that have proven efficacy at reaching out to specific communities, communities of color, trans communities, other communities, in order to let people know about this program. Next slide, please. So I'm going to go very quickly, so maybe we have 5 minutes for questions. But for a PrEP pass, again, what we're looking for is we're looking for a simple way to cover those medications and labs. In terms of physician costs, right now we're trying to not let the perfect be the enemy of the good. So we want to work with CDC to find out what's the easiest way for medication and labs, and really work through grants as we're doing that sort of network expansion to be the way that we're covering those physician costs for individuals as they are accessing services within their communities. Next slide, please. In terms of that second bucket of expanding the network of providers, this is just a visualization of what a hub and spokes could sort of look like. This is not an exhaustive list of all of the different spokes that could be there, but it gives you a sense of what that would sort of look like if we could leverage teleprep in terms of access for people. Next slide, please. And finally, in terms of the third bucket, I'm not going to go into all of the bullets here. But really, again, we want to have demand creation that is not just status quo, that is both national and local, so that we are really paying attention to tailored needs for communities. Because a lot of times we get caught with our campaigns sort of talking within our own bubble, and we're going to need to make sure that we can reach outside of that. Next slide, please. So just briefly, where we want this to go and how we want funds to be distributed is what I already referred to. We are calling on Congress to give funds to CDC. What you see here is that there are other activities across HHS that are also working on PrEP access. And so we want to make sure that we're intentional, that we're tying that across all of those services so that it's not becoming confusing or competitive. But we see CDC as being well poised to coordinate all of these different funding streams in order to address all three buckets of access. So one, we believe that CDC is well poised to establish that centralized federal reimbursement mechanism, or PrEP pass. We see it also important in the context of places like Tennessee, where we're starting to see that HIV prevention can be politicized on the state level. And so we want to see a PrEP pass that isn't so exposed to politics at state and local levels, if we're headed in that sort of direction. We also see CDC as being an established grant maker that has relationships with health departments and community-based organizations that can establish the types of grants that we need in order to develop that hub and spokes model, to go out and build that network, open the floodgates on PrEP, leverage teleprep, and get those campaigns out there so the community knows about it. Next slide, please. I think I covered everything. It was a bit of a mad dash to try and get all of that in there, but the last thing that I just want to leave everyone with here, and again, thanks to everyone, and echoing what Jim said, for sticking with us here. But there's a lot of complexity, but we have a lot of momentum here on this particular issue. And so we really encourage everyone on this call to be part of the conversation. This QR code, if you scan it right now, you can sign on to a letter. We've already sent the letter previously, so we're not probably sending it again in this particular format, but it will get you on a list so that as new developments come up for advocacy opportunities for this, you can be part of that conversation. And I encourage everyone here to be an advocate on this. If you have connections within CDC, echo that a national PrEP program is a priority right now, and that we need to have it happen in line with all of the community expertise that has been built over the past 2 years, that they need to be meeting with us, talking with us, and really cooperating and collaborating with us. We also need for elected officials to be hearing about this work and to become champions. And so where you have connections within your own community, within your own work, with potential champions within Congress and elsewhere, we welcome the opportunity to meet with them and are happy to connect with anyone who has a lead on who we should be talking to try and elevate this as a priority as we seek additional funding. So with 1 minute left in the webinar, I'm going to turn it over from there. Many thanks to Greg and Beth and John and Ben for convening us, and to my co-presenters for a great conversation today.
Thanks, everybody. Of course, we, being the clever folks that we are, we did build in an extra 15 minutes of discussion, so we do have until the top of the hour. So why don't we go ahead and take down the slides, and then if people have, oh gosh, where's the screen? You can raise your hand and ask a question. Let me just find my, I had to change my view. Gallery, there we go. Okay, so Robert, it looks like Robert Wilder. Please go ahead.
Thank you everyone so much for these presentations. I wonder if you could talk a little bit more about being able to design a federal program that can be accessed directly by patients and by providers that does bypass state and local, I was going to say interference, but that's not a very nice word, regulation or involvement.
I'm happy to jump in real quick on that. You know, again, that's where we're really hoping that we can work with CDC to develop a federal PrEP pass that is accessible to providers and patients from you know, a portal that is established through a contract with CDC and a billing administrator. And there are a couple of different reasons that we want that. One is, you know, there is potential interference right now. We're hoping that the situation in Tennessee doesn't spread elsewhere, but it simply is a reality that the CDC may be better insulated from that kind of interference and being able to cover medications and labs. The other part is that even amongst health departments that you know, may not have so-called interference, it's a lot of work to set up these individual mechanisms. It's a lot of work and complexity to negotiate on drug pricing and fee schedules and monitor all of it. And so we really would like to deduplicate that effort, take that burden off of health departments a bit and put it at CDC, where they really should be owning national PrEP access even more than they are. So that's my take, and welcome any additional comments from my co-presenters.
All right, Christopher.
Well, no, thank you. It's funny. I think I've actually asked. Hi, Jeremiah. I think I've asked you this question before because I bring it up because I think it's a good topic. So hopefully that's okay. Going to this idea of what other states are politically doing on their own and the sort of slew of anti-trans youth bills, minor consent laws trying to be revoked. Just curious if anyone's had any thoughts on ways that this kind of program and some of these other things we're talking about could support folks under 18 having some equitable access. And I know that is a challenge, but I'm just kind of curious if anyone has any thoughts on that.
So I can jump in about under 18, and I'll just say that there are efforts underway in Chicago to really work on that. Some people may be familiar with the PrEP for Love campaign. That campaign has spawned or birthed a baby that has just come out of the birth canal recently and got some funding called PrEP for Teens. And so we'll be doing a social marketing, creative arts-based campaign led by teens, created by teens in Chicago to help make sure that they understand that they are able to get PrEP. As far as we know, there are really no full-bore social marketing campaigns in the country that focus on teens. There may be some small efforts, but not like a full-blown, big-ass social marketing campaign. So we just got all our funding ducks in a row, literally like last week. So hopefully we will be seeing some output this year in 2023 to help with that.
One other thing. So I'm in Cleveland, Ohio, and so there are a couple things here happening. One is the Cleveland Metropolitan School District is about to actually build more kind of medical clinics in the school setting through a partnership with Metro Health, which is our county public kind of hospital system. And I think that's going to be a good kind of direct way to provide like PrEP and, HIV and STI services to young folks as one. And I had something else too that I'm now forgetting, but I'll stop. If I remember, I'll come back to me, but that's one of the things. This is what it was. Also because I'm the board president of the LGBT Center of Greater Cleveland, we have a similar partnership with Metro and with another hospital system here where we do direct, they kind of come in a few days a week and do direct medical services at the LGBT Center. And we have a youth program. And so a lot of young people actually come and, get medical services there through. And so that's another kind of a strategy to try to deal with that gap.
Yeah. And just one thing on that, and actually this sort of dovetails a little bit with Connie's just most recent question in the chat, which is that number one, I think particularly around thinking about adolescents and even just young adults, like many of whom are like perhaps like on their parents' insurance plan, if they do not want to leverage that just because of the sort of like the statement of benefits and not sort of being registered there really isn't a very good mechanism, including under manufacturer patient assistance programs for them to provide that. So that's one big priority there. Number two is that, a lot of students, when you take a look at schools, a lot of schools are not 340B covered entities. They're not 340B covered entities, so they cannot purchase medication at a discounted price, right? So I think if they want to ensure just like, just straight up access, to medications, through those programs, generics are going to play a really, really large role there. They'll play a really, really large role, particularly like sort of in that that schooling, even that university setting, because 340 just does not play there. So to Connie's point, 340B is a huge opportunity to leverage lower cost products to the branded products. But I think there was a comment made earlier today that when you take the generic prices and then you bring on the 340B discounting, really generic drugs can be accessed for pennies, which is such a super important thing.
Great. Thanks, Tim. Let's turn it over to Brianna for a final question, and then we have some closing polls at the end and maybe a quick discussion.
Yes, I wanted to talk a little bit more about 211 and why, when that regimen is prescribed, it's only prescribed to gay men.
I can hop in there. 211 was only tested among gay men, so that's why gay men. And I think there's some transgender individuals, but mostly gay men. So people having anal sex. 211 was tested, and so they can't. And if you know that CDC, while CDC mentions it in the guidance, they have not formally approved of it. I do want to take this moment though to say that there was some new really exciting data that came out of CROI 2023. Dr. Jeannie Marazzo did this enormous analysis of over 6,000 cisgender women the world over who were accessing oral TDF-FTC for PrEP through demonstration projects. So these weren't clinical trials. They didn't have multiple choices. It was, if you want to come for PrEP, you can come here for PrEP. So they were choosing PrEP. And she was able to show through her analysis, because all these demonstration projects were factoring in adherence, et cetera, that cisgender women can take 4 pills a week and have robust protection. 4 pills a week, robust protection. We've been telling cisgender women up till this very moment that they have to be super adherers and take 6 to 7 pills a week. CDC continues to say that cisgender women need 21 days of pills before there's enough protection for them for insertive vaginal intercourse or receptive vaginal intercourse. And so this new data, I'm hoping, will change policies, programs, and procedures. We need to be telling women, cis women all over, that they don't have to be superhero adherers to get a lot of benefit from PrEP, that 4 pills or more a week equates to substantial protection, just like it does for anal sex.
So can I just say one more thing? Because when we talk about ending the epidemic, isn't there a problem with the messaging then?
So
I think, I mean, I think, and if I'm picking up on it correctly, let me know, or if I'm getting it wrong, please let me know. I think it's always been this kind of weird thing as someone living with HIV to talk about ending the epidemic, because it's like, but there's no cure. So I'm still going to have to wake up every day, and take pills or get injections. So it's never, will it have really ended for me? So I think it's an imprecise language. What I think is, the driving force behind that language is that we're trying to get the number of new HIV infections down so far that it's no longer at epidemic level in our communities. So it's a distinction. It's something that's a bit in the nuance, but definitely, I think an understandable conversation, even though I think we're a bit far down the path of the ending the HIV epidemic language at this point.
Thanks, everyone, and thank you to all the presenters and panelists who I thought just did a super job. There's so much information to digest. And Ben, if maybe you could share a couple of our last poll questions, because we really did want to focus on next steps and how we can apply what we've learned. So if you wouldn't mind going back to the poll, we are doing this through Poll Everywhere, right? Yes, thank you. So please go back to your poll and talk about, and please enter in one item that you learned today that you can use in your work. These are fabulous. We were going to spend some time talking about actually how to put these into practice. I don't think we have time for that, but I think I will put up our final evaluation in Zoom, just so we can get some feedback for our funders. I will launch that now. So we'll have 2 polls going on simultaneously.
And on that
Great.
Zoom, please be sure to scroll down. We actually have a number of questions nested in
There are
there.
6 questions on this poll.
Greg, are we allowed to evaluate ourselves as speakers? Is that? I'm joking.
Sure, yes, go for it. You have an important perspective too, right?
I don't trust the voices in my head. I'll leave it to everybody else.
Beth, while the poll is up, are there any other closing comments or statements we want to make?
Yeah, I've been keeping an eye on the chat, and I think I will share the comments with our speakers afterwards and use them in our planning. I think there was one specific question in there around if anyone knew who was behind some of those lawsuits that were mentioned earlier.
Oh, on the Facebook.
Yeah, that was during Jim's presentation.
Mm-hmm.
I've definitely had that question before. I don't know. I mean, you know, the conspiracy theorist in my head, in the crowd of people in my head, would say there could be a pharmaceutical company who was helping to make that happen. But we know there's a lot of lawyers who are ambulance chasers, and they smell blood in the water and they go for it. So I mean, there were so many, and there's so many different variations on the theme. I don't think it was all. I don't personally think it was all coordinated, but I don't have any, you know, I don't have any facts here. I just have my gut instinct.
Yeah, and I'll just say to that, just one thing they are decidedly not, which is community centered.
Right, not at all.
Well, with that, I think we're at the top of the hour. I know many of us probably have to run to other meetings. Thank you all so much for your dedication to stick with us this long. Don't forget, we have the National Transgender Health Surveys Conference Summit coming up in May. John and Mika has shared links to our resources, so please feel free to sign up for additional announcements. There are some PrEP presentations happening at the Trans Health Summit, and I hope to see many of you at the NMAC Biomedical HIV Prevention Summit in a couple of weeks as well. Take care, be safe. And don't forget to get your bivalent boosters if you haven't already. Thank you much.